We're talking about setup procedures for the home care patient on biphasic thoracic ventilation. Okay. So, to begin with, we're going to talk about the things that should be in place for you from the setting selection process. Now, setting selection can be done either in the hospital at the acute level by the physician who set the patient up and then referred him for home care. It can be done in the clinic by the physician or the therapist caring for the patient in clinic, and you could have orders for settings from that venue, and we're just validating the settings once the patient's at home. Or part of the setup process may be setting selection. However, setting selection is not always part of setup, but it can be part of setup. And when we do setting selection, and when we look at setting selection, you'll see there's some very specific things that we want to have pass forward from setting selection to the setup process. Okay? In the setting selection, part of determining the right setting for the patient is to begin with determining our goals for therapy. And those goals should be documented somewhere in the notes from the setting selection process. So you should have some goals already formulated for you when you go in to do the setup. Now, part of documenting the setup is to do the formal documentation of the goals and take into account those goals that were established at setup if they were documented then. If they were done by, your setting selection was done in the hospital by a physician, they may well not have documented specific goals. But if it was done by one of our clinical people, then they should have given you some documentation of their goals of the therapy for the patient. Okay. Your settings and why they were chosen should be documented, particularly if any of those settings fall outside of what we consider normal settings. You should have notes as to why they were selected and why they're being used to help you determine going forward if those are the right settings for the patient. Any reasons, like I said, the settings are outside the normal range. In the process of selecting settings, the patient and the family are introduced to BCD and their concepts. They're not perhaps trained on use of BCD, but they should already be well acquainted with the concepts of BCD. Part of the setup process is to do that rest of that training with the patient and family on using the device. Okay. Training will not have already been done. If it was done by a personal support clinician, the titration or the setting selection, then you may want to contact that clinic if you need additional delineation as to why those settings or why the sides of cuirass were chosen and placed into the order. Prior to the visit, you're going to have an order. You want to verify that you've got the order and that it makes sense. Any historical data that you provided, review that so you know your patient a little bit. There should be plan of care elements from the titration. As I said, your goals from the titration or from the setting selection process and any other issues that might have been documented. Make sure you got your equipment and supplies. Sometimes the equipment and supplies will be sent to your home. Sometimes it will be sent to the patient's home. If it's sent to the patient's home, call ahead and verify that they've got everything that you're going to need. You should have a machine with stand, a cuirass with seals, a large bore tubing, and pressure lines. That should be it, but make sure that those are all available for you before you go. Schedule your visit, confirm in advance. If there's travel involved, trying to travel as soon as possible. Sometimes we do travel, various places. I've traveled across the country to do setups, but that's not going to be typical for most per diems. They're working locally. Your visit, call ahead by about 30 minutes if possible. Arrive on time. You should have a personal support name badge. We don't have those out to everyone yet, but that should be part of something that you have. Typically, you're going to show up in scrub attire. And my advice is to go to the door first without your equipment and supplies if you're bringing the equipment and supplies with you. You want to form a little bit of rapport with the patient and family, so a brief visit before you bring the box with the machine and the stand into the house is probably best. Okay, introduce yourself. You can request generic personal support business cards that have the main number on them. So if you don't have any of those, please make a request to Michelle to get a few. Spend a brief period without the equipment to discuss the steps that they went through with the setting selection process, their particular goals and expectations. They may have pie-in-the-sky goals for this, or they may not even understand what the correct goals are. So correct any misunderstandings, reinforce the benefits of use for the patient, go over the setup process and what you're about to do, outline the paperwork that you're going to cover. So during that time, you'll probably be able to form a little bit of rapport with the patient. Locate the setup site. If it's going to be a bed, mostly at night, a nocturnal use device, it's best to do the setup at the patient's bedside. So find out where the patient's going to be using this, and assist the caregivers with planning routine use. They'll have to find a location near the bed next to the patient for placing the machine and a place to plug in with grounded outlets. All those things will have to be considered and help them to determine how they're going to make it work in their home. Okay, then once you've formed a rapport and you've spent a few minutes getting to know them and talking about what's going to happen, bring the equipment in, set up the stand and the machine. The stand, there's a 5 or 6-legged base, and the wheels go onto the base. They're easy to push into the base. And there is a small stub that goes in the center of the base and then a pole that goes on the stand. Make sure and set that stub really good into the stand. And then there is a Allen wrench that comes with the pole. Make sure that the set screws are to the bottom on the pole, and then set them with the Allen wrench that came with it. And usually there is a foam insert in the pole. Usually we place the Allen wrench down into the foam within the pole, and that keeps it always handy if we ever need it again. That's a typical process. So you may find that the Allen wrench already in the foam at the top of the pole if the stand has ever been put together before, and that's not unusual. So set up your stand, and then the base for the machine goes at the top of the stand. It sits on there very nicely, and then the machine goes onto the base. Make sure that the ventilation holes under the machine, there's different size ventilation holes and different size openings on the base. Make sure that they match up, because if they do not match up, the machine will actually go onto the base backwards, and there won't be adequate flow through the machine, and it will cause it to heat up. So make sure that the machine is on the stand with the ventilation holes in the bottom of the machine lining up with the openings in the base of at the top of the stand. Okay, start out getting your assessment data. There is a form, an admission assessment form that you're going to fill out, so you can begin getting that information. And then you're going to go through the admission assessment and plan of care form with the patient. Usually I get that initial piece of paperwork out of the way before I begin training on it. That way I get the assessment data out of the way. I'm formulating the care plan with the patient and family as I go through this, so that piece of documentation is knocked out for you. Okay, so now we're going to talk about that form, the admission assessment and plan of care form. Okay, all of these forms, you'll see this over and over, leave no blanks or check rows unfilled. If it's NA, mark NA. If it's a couple of check boxes that don't apply, draw a circle around them, write NA off to the side. But every row is an important element that is required by our policy and procedure and by accrediting agencies for us to have documented. And although sometimes these forms have some redundancies, every element in these forms and every form is a requirement. So please leave no blanks unfilled. Your care plan will have identified needs or problems, expected outcomes, and actions. Okay? So those elements may well have been documented in the setting selection process. And if they were documented previously in the setting selection process, or if you've done the setting selections yourself and are doing the setup now, move that information forward into your care plan on the admission assessment form. If they were not documented, it's nothing to get too concerned about. It's just go ahead and formulate your own identified needs, which are the patient's problems, your expected outcomes, which are the goals for the patient, and actions to achieve those goals relative to those problems or identified needs. And your actions are generally just going to be use the Hayek for support or use the Hayek for secretion clearance and assist cough. That those actions should be able to achieve our expected outcomes or goals. Okay, so we want at least 3 on each patient. Now, these care plans are long-term care plans. Once they're established with setup, unless there's a significant change in the patient's condition, the care plan can be carried forward throughout the long-term care processes. Short-term issues can be documented in your SOAP notes that will be done with follow-up. But all of our care plan documentation should be long-term issues. So you're going to find at least 3 problems that we're addressing with the Hayek and make those your long-term need problems. And many times if you have the history and physical or discharge summary, the needs and problems are very clearly documented by the physician in those documents. So if you have the historical data, oftentimes it's very simple to get the problem list together for the patient. Okay, and then relative to the problems that we identify, we want at least 3 goals or expected outcomes. These are long-term goals for the patient. And then relative to those 3 goals, we want 3 related actions. Again, that's going to basically be use BCV, whether it's for support or whether it's for secretion clearance and cough assist, to achieve the goals, again, relative to the problems that we've identified. The more that we develop the care plan, the better, within reason. We don't want 52 identified problems and 52 goals and actions relative to that. 3, 4, 5, 6 usually are going to be enough to develop your care plan, but we want at least 3 documented problems, goals, and actions. Okay. Work through this. Once you've got an idea of what's right with the patient, work through it with the family and the patient. Make sure they're involved in the process, and base it on your assessment of the patient and the historical data. And they should be very specific to the patient's condition, symptoms, and diagnosis. And this care plan will be the foundation for the patient's care plan as we go through the long-term care of this patient. Okay, and just to touch briefly on care plan in general, the flow should be assessment. From the assessment, we determine the patient's problems based on that assessment. We establish goals related to resolving or mitigating those problems, and then establish actions to achieve those goals related to the problem. That's care plan basics. And our BCV care plan, as I said, should have 3 or more patient pathology-specific problems for which we're using BCV. You should have 3 or more expected outcomes or goals specifically related to those problems, and we should have 3 actions or more related to the expected outcomes that are related to the problems that we identified. Okay, a simple example of the care plan: identified needs may be neuromuscular compromise related to ALS, resulting in problem 1, poor ability to perform activities of daily living with rapid onset of fatigue and shortness of breath with any increase of activity. Problem number 2, an inability to inspire deeply related to neuromuscular compromise. Problem number 3, inability to generate adequate cough to clear airways. Our expected outcomes or goals related to those 3 problems are to maximize endurance for performance of ADLs with better tolerance of brief increases in activity, improved volume expansion and chest wall mobility, and third goal would be improved airway clearance. Our actions relative to those goals: 1, we're going to utilize BCV as prescribed for rest at night during naps as needed, provide rest of pulmonary muscles and improve endurance. And then action 2 and 3 are going to be utilized BCV as prescribed for rest, also use secretion clearance and cough assist to improve depth of respiration and clear airways. So there we have a very basic care plan established with identified needs and problems 1, 2, and 3, expected outcomes 1, 2, and 3, and our actions 1, 2, and 3. Okay, so our partial list of needs and problems that will potentially respond to BCV. Now this, I'm just going to put it up here, if the computer will help me. Okay, recruitment of alveoli small airways, conditions requiring non-invasive support for relief of work of breathing, small airway disease, need to improve oxygenation. Okay. All of these are potential problems that can respond to BCV. And that none of these may be appropriate for your patient, or several of them may be appropriate for your patient, but you get the idea. We're trying to determine what is the issues that we're treating the patient for with the Hayek. So that's what we're after right here. And these can be related back directly to their diagnosis. So the patient may have ongoing need for recruitment of alveoli and small airways relative to muscular dystrophy. So whatever those are, you can relate them back to the diagnosis. But again, these are to be long-term problem lists, not a short-term profile. Okay, possible expected outcomes, possible goals. These are some of the goals that we might have for our patient that's using BCV. Again, this is a limited list. You may determine goals for the patient based on your assessment, and it may not even be on this list. But these are the types of things that are goals for the use of BCV. So this would be maybe your goal for the patient. So your patient needed airway clearance and pulmonary endurance or pulmonary chest wall expansion related to their muscular dystrophy, and we want to make our goal is to increase pulmonary muscle strength and endurance, or any of these things, increase lung volume or cough load. Whatever your assessment is of that patient's needs, determine your goals based on the problems you identify. And then our actions would usually be to adhere to prescribed use of BCV for support, secretion clearance, or cough assist as is appropriate to the problem and expected outcome that we've identified. Okay, once the admission assessment is completed, then we begin training and instructing the patient and caregiver to prepare for independent use with the following objectives. We'll be looking at the paperwork elements, and those get completed after your training is done. So objective 1, we want to instruct the patient on the equipment and the supplies that are needed to apply BCV. When I said before, the equipment that you want to make sure is there if it's being sent to the patient's home, you need the control unit, the Hayek RTX, you need the stand, and just, I don't know if that was confusing or not, the Hayek RTX is the control unit. The stand, you need the large bore tubing, you need the pressure line. There are 2 pressure lines potentially. If the patient is on a triggered type mode, there will be an airway pressure line, and there will always be a Kuros pressure line. So there are 2 small pressure lines, one's blue and one is clear, and then you should have seals. Typically at the setup you get 5 seals, and the patients will routinely get 5 seals a month. So then you're going to instruct them on assembling the elements of the system with particular attention to placing the seals on the Kuros. And you will find, if you have not already, that probably one of the most difficult elements of applying BCV initially is developing skill with placing the seal on the Kuros. And I've had people say, oh, that's so hard. It's a skill. After you learn to do it, it becomes more and more and more easy. It's probably, the way I look at it, it's probably far less difficult than intubation or placing a crate. So it is one of the challenging elements of applying BCV, but it has to be that way so the steel adheres to the Kuros real well. So it's something that you want to pay particular attention to when instructing the caregivers. I always want them to give me a good return demonstration of being able to put on the seal. So show them and then have them return demonstrate to you so that it's clear that they have that particular skill at least initiated. Okay? And allow them to repeat. Take it off, put it back on, take it off, put it back on until you're sure they're comfortable with that process. Because if the seal were to have any kind of problems, one of the issues that can cause difficulty for the patient is the seal needs to be replaced and no one knows how to put it on, or it's not put on correctly. So you want to give them an opportunity to demonstrate that they know how to do it. And you have them power on the unit, have them instruct them to not have the patient attached. We never want the Kuros on the patient when we're powering up because the RTX is going through a self-test, and it is zeroing the pressure transducers, and if it is connected to the patient, it will get a false baseline. So make sure it's not on the patient. Make sure they understand not to have it on the patient when it powers up. Also, as it's powering up, there is a box that appears for a few seconds that has the hours, the unit hours on there. At some point, they may be contacted by the home office to find out what the hours are on the machine, and we want them to know where the hours are located. So as the unit powers up, they'll be able to determine the hours on the unit, and that box goes away after just a few seconds, so they need to catch it as it's right after its self-test. The apnea alarm needs to be zeroed. So in equipment training, when you do your hands-on competency with the equipment, make sure that you're shown how to zero out the apnea alarm. The apnea alarm is an extreme nuisance alarm unless it is zeroed out. So it is something that we do not routinely use, and you want to make sure that you know how to zero it out. It's just a matter of going to the alarm menu, going down to the apnea interval, hitting over on the numeric keypad the number 0 and changing that 20-second default apnea alarm to 0, and then that zeroes that alarm out. There will still be alarms in play. The disconnect alarm is undefeatable. You can adjust it, and it will continue to alarm if there's ever a disconnect of the tubing or the Curos loses its seal. So we just don't, that apnea alarm will ultimately become a nuisance, and we want to see it zeroed out. Okay, you want to go through and enter all the prescribed settings on the machine that were determined at setting selection. And one of the things that we want to make sure of, even if CNEP is not part of the prescribed settings, so some patients will have CNEP as a therapy or as one of their support settings that were determined from setting selection. If the patient is not prescribed for CNEP, make sure that it's set at -10. That's a pretty benign setting. Nothing can be hurt if the patient happens to go into that setting by accident. And you're always going to use it to seal the Curos on the patient's chest anyway. You just don't want it set at -40 or some haywire value. Also, while we're on the subject of settings, entering settings, it's a good idea to go through all the modes, even modes that aren't prescribed, and make sure that none of the setting numbers are in the extremes. So you want to look, even though the patient may not be ordered for respiratory triggered, jump into respiratory triggered and make sure the inspiratory pressure is not at -45. Set it similar to the settings that are ordered for control mode or for respiratory synchronized mode. And make sure the 3 support modes, respiratory synchronized, respiratory triggered, and control mode all have similar settings. And if the patient's not ordered on them, he's just ordered on continuous negative, set them to some moderate settings, say, for example, -18 +6 at a rate that's normal for the patient's size and age. And that way, if they happen to fall into those settings or go into those settings by accident, it's not going to be anything that's extreme. Okay, you want to instruct the patient and caregivers that only the settings that are ordered are the settings that they're to be left on. Okay, you will be teaching them how to change mode from their support settings that are ordered to airway clearance if they're ordered for airway clearance, and then back. So they'll be doing mode changes, but they are not to change the setting levels. That requires a physician order, and it is part of our protocol and part of our evaluation process to make those adjustments if needed. But we don't want the patient doing that. Okay, instruct the patient on the basic screen element. So along the left-hand side of the screen, you have your recorded values. The top values are from the Curos. The second row is from the airway if you're using an airway sensor or airway pressure line. The graph shows pressure waves that are being recorded from the Curos on the top graph. The second graph shows pressure waves that are being recorded from an airway sensor if one is being used. And along the bottom are the settings that are currently active. Along the right-hand side are any alarms that are in play. And typically for home use, we're only going with the disconnect alarm. So most of the alarms, or if not all the alarms, should be zeroed out. You want to instruct them on how to enter the setting changes that will be required for the patient. As we said, they will be changing from their support mode to secretion clearance and back if they're ordered on secretion clearance. So you just want them to understand how to make that setting change only. And always, every mode has to be started. There is a start-stop key on the keyboard, and you want to make sure that they know just because they put the machine on control mode, it hasn't started until they hit the start key. Okay, and it's very important that we help them to understand they need to be there during secretion clearance. One of the things that can occur at any time while the patient's taking secretion clearance, I mean, it can occur at any time while they're being ventilated, but the odds increase a lot when they're taking secretion clearance, that a plug may present at the airway and the patient may need assistance clearing the airway. And this is much more serious with patients that have no ability to care for themselves. So a neuromuscular patient that can't really do anything to clear their airway, that has to be suctioned for clearance. If a large plug that's been broken loose from deep in the lungs presents at the trach or up in the upper airway, then the patient needs somebody to be there to help them clear that out. So it's important that someone be there in attendance or very nearby while the patient's taking secretion clearance therapy. Okay, the steps of application need to be reinforced. Always start by putting the straps behind the patient, and then place the cuirass. And when you're demonstrating cuirass placement, remember you flex it out somewhat. Don't just push it up to the chest and shove it on, which is a common mistake. That really is hard on the seals. It will wear them out much more quickly. The cuirass needs to be flexed out and around on the patient's chest. And then once it's on the patient's chest and it's pretty obvious that you've got the seal down to the chest, then you seal it on by initiating continuous negative. So place it in continuous negative mode. It should be set at -10 or the prescribed setting level. Hit the start key. Once the cuirass is pulled down to the patient's chest and reached and leveled out at the set pressure, then bring the straps up. That is our process always. Always start out with that, because if you put the cuirass on, then strap it on, and then start it, once there's some compression taken out of the seal, the cuirass will be moving too much on the chest to have as much effect on ventilation as it should. So we always want to take some compression out of the seal by starting with a period of continuous negative, then bring the straps up. Once you've got the straps on, then you initiate prescribed mode. Okay, once you've demonstrated that and gone over the steps, ask them to go through it. Ask them to show you how that was done. So you're certain that they're comfortable with it. Okay, when you are initiating BCV for the patient, you want to remember to use care. There's certain patients that are very challenging to transition from their other means of support. So some patients that we will be setting up will be on mask BiPAP or maybe on positive pressure ventilation, and we're moving them over to the cuirass as their means of ventilation and support. And for those patients, sometimes the transition is very easy. Some of those patients are able to breathe on their own for significant periods of time off of support. However, there are other patients that are unable to breathe for any length of time at all off of their other means of support. So we have to be really careful with those patients. So just be aware, there should be, if the patient is a challenging transition, the setting selection process should have made that clear, and you should be able to tell, or from your assessment of the patient, you'll know if he was a high cervical spine injury quadriplegic, then you'll know this patient may be challenging. Or if he's a very far advanced ALS patient with very little spontaneous capability, those types of patients are going to be more challenging. So just be aware from your assessment and from the notes that may have come from the setting selection process as to where that patient falls in that spectrum. It's much easier if the patient is able to breathe for long periods of time off of support, but you will occasionally encounter patients that cannot. So they may require a more gradual switch. And BCV on the Hayek RTX, the current unit that we have, there is a ramp function that was mandated by the FDA. It does not immediately go to the settings. So, for example, if the patient needs minus 24 plus 8 as their final settings for BCV, you will place the Curos on, seal the Curos, and then start the control mode in 24/8. That it may take, if you'll watch the numeric readout, it will take sometimes 5 or even 7 minutes because of that mandated ramp function before you reach the full settings that the patient needs. So if you've got a patient that's unable to move air on their own at all, you don't want to remove them from their other means of support, whether it's non-invasive or invasive, until the Hayek has reached those full prescribed settings. So you want to give them some time. Allow the Hayek to ramp before you take off the other means of support, or you may have a patient that will fall into some real serious shortness of breath or desaturate. Okay, use patience. Don't rush the process. This sometimes an event like that can really get the patient nervous, and you might wind up having your whole trip just stopped right there if you scare the patient. So be careful. Use your patience, and don't rush the process. You want to have a pulse oximeter so that you can use that during these transitions. Although I know pulse oximetry is not an immediate result type of information on ventilation. You will at least know if your patient's stay in the safe range, and if they start dipping, then you know hypoventilation may be part of that issue, and you'll know to get them back on their normal means of support, back up briefly, and then start over again. So a pulse ox is a nice non-invasive tool to have handy as you're doing this transition. Once you've done the transition and you've got the patient moved over, then that transition has to be able to be return demonstrated by caregivers for the patient. It's something that you want to make sure that they are able to duplicate. So once you determine the steps in the process, and you're working through that with the caregivers present, have the caregivers return demonstrate, because the patient may continue to use their non-invasive or their invasive positive pressure support on occasion as backup and have to transition back and forth. So the caregivers need to know how to do that. Okay, once you get the patient established on BCV, you want to make sure that the settings that were chosen in the setting selection process are adequate for the patient. Okay, request subjective patient input using your pulse ox and vital signs after the settings have ramped fully to make sure that the patient is comfortable and that the patient seems to be getting ventilated adequately and all the vital signs are falling within relatively normal range for the patient. Okay, you should have some notes, or you should have generated some notes if you did the setting selection. So the patient should have similar responses as had occurred in the setting selection process. If there's any unexpected responses, setting adjustment may be indicated. So once the RTX ramps up, if the patient still doesn't feel like he's getting a deep enough breath, or feels like he's short of breath, or he feels dizzy, then there may be some setting adjustment that may be indicated. If unexpected results occur, document this, and you may want to contact the intake personnel or your clinical specialist to help you work your way through it. Okay. Also, you want your caregivers to demonstrate execution of secretion clearance treatment. Now, something that really, where the secretion clearance makes a really big difference for patients is if we can teach them to coordinate their own cough effort, even if it's extremely weak, if they have any ability to cough at all, we want them to coordinate it with the cycling of the RTX. It's for that reason I like cough assist rates that are divisible by 12, because they will always fall one on top of the other on the graph, and you can teach the patient to watch the graph and know exactly when the cough is going to come. I usually like to use 24. I find that 48 is too many and 12 is not enough. So 24 works really well for me. Whatever is prescribed, you want the patient to put their cough effort in conjunction with the assistance from the machine. Also, you can give the patient an extra boost in cough flow and cough force by just taking your fingertips and placing it on the front of the Curos, and you give a slight push against the front of the Curos as the assist cough is occurring, and help the patient even a little bit more. And that there'll almost always be some leaks around the edge of the cuirass during the cough assist cycle, but if you will go ahead and give the patient some assistance, you'll seal up some of those leaks, and you'll get a little extra pressure, a little extra push during the assist cough phase, and that'll help the patient generate greater flows. Whether the patient is assisting with that or is unable to assist, it makes almost anybody an expert at manual assist cough maneuvers, because you're getting the cuirass as a helper. Make sure the family learns how to do that. Make sure the patient learns how to coordinate their cough efforts with the cycling of the machine. Also, it's important that they recognize that any time during the therapy, the machine can be stopped. So if the patient brings up a large bolus of secretions and needs a minute to have their oropharynx cleared out before they progress, the treatment can be stopped. The thing to bear in mind and to teach the family is when you stop secretion clearance, it is a timed treatment. Each cycle is preset as to time for duration of oscillation and duration of cough assist and the number of repeats. So if you stop mid-treatment and then you resume, the machine starts back over at the very beginning of all those time intervals. So they may need to remain aware. So if there's, for example, 5 cycles that are prescribed and the patient has done 3 and the treatment is stopped, then once they resume, they'll only need to continue through 2 of them if they want to complete the prescribed treatment. So just that's something to be aware of. But if they need to at any point, the therapy can be stopped so the patient can clear his airway, or if they're uncomfortable for any reason, that it can be stopped for them. The thing to bear in mind, if the patient is on support when they're not taking secretion clearance, that they will need to move them over into support. And another thing to bear in mind is at the end of the treatment cycle, so let's say it's set for a 30-minute treatment. At the end of that 30-minute treatment cycle, it goes into standby. And then someone needs to be present to put it back into the support mode and to resume support if the patient needs to go back onto support. Okay, and that covers that. All right, you want to instruct patient and caregivers on some strategies when they're not able to establish a good seal. Basically, it's a matter of locating the point where the seal is not meeting up with the patient's chest wall or abdomen. And you can kind of run your fingers around. It's most typically at the top or the bottom. Perhaps the cuirass is not all the way seated onto the chest as far as it could be. So if you find that it's at the top of the sternum or down around the umbilicus, you can just kind of respread the cuirass and seat it onto the patient's chest a little bit better. Sometimes the only answer is to remove it, make sure the seal's on good, and then reapply it again from scratch. But the most frequent error code will be an error related to the fact that the cuirass is not attached on the patient's chest all the way. So once they find that they've got an error code related to a leak, or the machine can't achieve its settings because of a big leak, then they need to determine where that leak is around the seal, and it's just a matter of feeling for it, finding it. And as they get more and more skilled with using it, that won't be a problem. But a lot of times initially it's just a matter that they aren't comfortable putting the cuirass all the way onto the thorax. Okay, the seals do wear. And the way that we determine if they are ready to be changed is mainly 2 ways. The edges of the cuirass over time, as the cuirass has the negative and positive pressure plates in it, the edge of the cuirass will work its way through the foam seal. And if the edge of the cuirass feels like it's about to break through the edge of the seal, or it has broken through, once the edge of that cuirass gets to the patient's skin, it will cause a breakdown almost for sure. So they need to monitor, and we suggest every 4 to 6 hours that you check the seal to make sure that the edge of the cuirass is not wearing through. When the edge of that seal is nearly worn through or is worn through, the seal must be changed immediately. Also, as the seal is used, it stretches. And we talked about how difficult it can be at first to put a new seal on a cuirass. Well, over time and use, that seal will stretch and it won't adhere to the cuirass like it did originally. So if every time the cuirass is removed, the seal is just falling off and it's not staying attached to the cuirass like it should, that's another indication that the seal needs to be replaced. So they need to know how to monitor for that, and then they replace the seal. Respond to any questions and reinforce where needed. Typically, most of our patients get 5 seals a month as needed. Many of the insurance companies have authorized up to 10 seals a month if the patient needs more. 5 is usually enough, but if they find that they're needing more, they need to contact the home office and request them. But for the most part, 5 a month is working pretty well for our home care patients. Okay, make sure they have ready access to contact information. In the information packets that you're going to leave with them will be numbers to the home office, and introductory information will be in there. Okay, review the prescription, complete all the paperwork, as I said before, leave no blanks unaddressed. Okay, so your setup paperwork, we're going to talk about that right now and how we complete them. So the mission assessment. Complete that as you complete the initial patient assessment at the beginning of your visit, as we talked about. Here's an example of the admission assessment. This was one that I did last year. And you can see we've got every blank. The diagnosis, you can put in code and the name of the diagnosis, or the name of the diagnosis is fine. We're doing a home assessment initially, an environmental safety assessment, determining if everything is adequate. This patient didn't have grounded outlets in all the rooms of the home, so it was recommended that they got grounded outlets as soon as possible. But actually in the patient's bedroom, there was, I believe, that were grounded in there, but we wanted it back up. And then we initiate a patient assessment, including sleep habits, mental evaluation, some vital signs, height and weight, breath sounds, secretions if present, pulse oximetry, and other pertinent findings. Okay. On the blank, other individuals and organizations involved in patient care. We want a complete list of all entities that are helping in the care of this patient, nursing services, D&E providers, in case that we have coordination of care issues with this patient. We know who the other care providers are. Okay, then you'll complete the care plan for the patient and family, leaving no blank unaddressed. You're going to get the 3 serial numbers and data for the Hayek, and we'll talk about that here in a little bit, and other equipment that's in the home on a separate sheet of paper if needed. So any DME that's in the home, if they have a suction unit that's being provided by a DME company, if they have a O2 concentrator, get the information on those other DME elements, and if you need to put them on a separate sheet of paper or on the back of one of the forms and send that in, we need to get that information. Okay, so here is the second page of the admission assessment. And as I said, you're going to get 3 serial numbers. Now it's one RTX, but it is performing 3 different functions if it's prescribed for 3 different functions. And we actually document those as if they are 3 different serial numbers. So you'll have your Hayek RTX. The ventilation mode is documented as RTX-V with the machine serial number -V. And the hours that are on the machine when you set it up, the settings that are on the machine when you set it up, as prescribed or as determined in the setting selection process. There should be a maintenance sticker present, and the maintenance sticker can have a due date or hours. So usually it's going to be hours, so note the hours for the next due maintenance. And then you'll have the RTX-O for the oscillation mode. There's a separate order for that, and it's treated as a separate device. And then we have the serial number, -O for oscillation. The hours are going to be the same. The setting for the oscillation phase, then sticker and hours are going to be the same. And then you have Hayek RTX-C for the pop assist mode, serial number -C, the current hours, and the settings that are selected or that have been selected for the pop assist mode. Then we get to our plan of care, our 1, 2, and 3 problems, our 1, 2, and 3 goals, our 1, 2, and 3 interventions to achieve those goals. And then patient has received instructions on what to do when respiratory care practitioner is not present. If there's problems, up to and including call 911. And then get the parent or the patient to sign. If it's not the patient, indicate who is signing for them, and then sign off on the document itself. Okay, the next element of the setup is going to be the delivery ticket. On the delivery tickets, they should already be completed for you with the serial numbers of the machine, or at least a blank for the serial numbers, and make sure you fill in the serial number -V, serial number -O if there's oscillation, and serial number -C if cough assist is ordered. For the 3 modules, verify the data is all correct. If there is, for some reason, something that is not present that is on the ticket, it needs to be back ordered and noted. Or if you happen to have an extra hose and the hose that showed up maybe had gotten damaged in transport, note that on the delivery ticket, and then have the patient or representative sign and sign the delivery ticket. Here's an example of the delivery ticket. The delivery ticket will show the different serial numbers we talked about, and then here is page 2. It shows the different elements that are delivered with the machine. Okay, and then medication profile is another document that gets completed. You want to complete for all meds and doses, routes, frequencies, and class of drug. And if you can determine, sometimes you can't because nobody knows, but if you can, determine the starting date, put that in. And here's an example of a medication list. Okay, anytime there's reviews or revisions with follow-ups, this can be accessed, and then you can alter, change, and update for whatever the current medication list is. Okay, and then the next document that's part of the setup process is the equipment management, mission assessment, and plan of care. So this is, again, there's a little bit of redundancy in this document because it's covering the equipment, and we did already cover the equipment in the initial mission assessment, but we have to do this relative directly to the equipment. It's a requirement. So complete it, leaving no blanks. Transcribe the machine data from your mission assessment, and with the 3 serial numbers, select the appropriate selection for the patient from the plan of service page, have it signed, and then you sign it. So this is the plan of service page. Check whatever elements are appropriate to the patient that you've assessed, sign it, and have the patient or whoever signs for them to sign it. And that looks like the same one. Okay, and then your home safety assessment, you complete it with no blanks. Here's the home safety assessment. This document as is appropriate for the patient, leaving no blanks. And then you're going to give them a patient booklet. This booklet is a general DME equipment setup booklet for all different types of DME that Personal provides. There is a blank on the receipt of patient booklet form. Note Hayek RTX in that blank for other, because Hayek RTX is not currently on the form. Print the patient's name and date and have them sign that they received that document. So here is that, and you'll notice here is the other down here, Hayek RTX. Okay, and then you're going to have them sign an acknowledgement of receipt of privacy practices. In the handbook is our privacy practices policy, and on the back of the form that we just looked at, and I tell you, I've missed this a couple times and had to get it, and go back and get it signed. But on the back of this form is that form. So make sure that you don't forget that on the back is the other form that we need, the receipt of privacy practices. Get that signed as well. Okay, and then we're going to have a progress note. I often do this after the fact. I like to do as much electronically as I can, but you can handwrite it. But your progress note should cover your introduction to the patient and caregivers, the fact that you reinforce the function and the purpose of the device, that you set goals with the patient and family, that you train them with adequate return of demonstration, that they tolerated the prescribed settings or your recommendation for retitration. If you are comfortable with the setting adjustment process, then retitrate and then submit a new titration flow sheet for order of modification. Unless it's not possible, we really want to go back and see the patient a day or two later, preferably the next day, and see how they're doing, reinforce and reassure them. Now, if they're a long ways from you and you've had a long travel to get to the patient, sometimes this isn't possible. So give them a call the next day, follow up and reassure them, and make sure and answer any questions, and add that follow-up data to your note that you did go back and see them or that you called them afterward. And here's an example of a note, pretty concise, but that's how, you can type them out or you can handwrite them. There's a form that has lines on it that's a blank progress note form. Okay, and then you need to complete your run sheet with every patient visit. You want to have a run sheet. This is how your visit was documented, and you submit this, and this is how they determine that it's time for you to get paid. So you want to make sure these get submitted. And this is a simple example of a run sheet. You're going to have the patient's address, what service you provided. This run sheet should have included time in and time out of the home. It didn't, but it does have ending and starting mileage, total miles to the patient's home, what time you started towards to go see them, what time you got back, and how long you were on the road. So that's all, that would be time on the road coming and going. Also, instructions are at the bottom on how to fill these out. Usually these are filled out by hand. I just had an electronic version, so for clarity and the fact that you probably couldn't read my handwriting, I filled it out on the electronic version and put in the example on there. Okay, so once you've got all the documentation completed, then you want to transmit everything electronically to the home office the very next day, if at all possible, no later than that. The sooner we get this in, the more quickly we can process everything and to get it into the patient record. So transmit as soon as possible to home office. It can be sent in by email from a scanner, or it can be sent in by fax, whatever you have available, but we want to get that in as soon as possible. And that completes the setup. Okay, so now we're going to advance into setting selection for the BCV clinician. So this is if the patient needs to be titrated, these are the steps to that process. We want you to be a little bit skilled in applying the Curos and setting entries before you attempt setting selection, but it's something that we like to see everybody graduate through over time. Until you're comfortable with the setting selection process, you can refer to the clinical specialist for your area to get that done and help you with that, or the patient will come to you with settings already prescribed from the hospital or the clinic, and you're just going to be validating that the settings work for the patient. So, talking about setting selection, I'm going to have one of these presentations that won't go to the next slide. There we go. That's the way to do it. Okay. The definition of the setting selection process is a process of artfully determining biphasic Curos ventilation settings that best meet the cardiopulmonary and clinical goals of the patient at home. This process is usually a patient's first introduction to BCV. The patient may be referred after setting selection by the referral source, so they may have been, as I said, set up in the clinic or hospital, and all you're going to do is validate the settings are effective to achieve the goals. Okay, now, something to bear in mind that's really important. The introduction period of the setting selection process can potentially determine whether the patient accepts the device. If they're frightened, and oftentimes these patients are really anxious, if it's frightening to them, then they may reject it. So you want to be careful. You want to proceed with care and with great sensitivity. So don't rush this portion of the process. Take your time with it. Most patients that require biphasic Kuros ventilation have very challenging medical and physical conditions and are often stressed and highly anxious. So proceed through the initial education and the reduction of BCV with sensitivity, allowing nothing to rush you. Okay. Don't advance into sizing or even setting selection or validation until you've answered all their questions, and as much as possible have them comfortable with the concept. Patients that have trouble comprehending, there's a video that is out on YouTube. If you look up, I believe, Hayek and Buffalo in the same search on YouTube, you'll find a video of the very first use. I have that video where it can be downloaded. So if you contact us, I can get you that video. And if you put it, I've actually put it on my phone. And for kids that have been anxious, I've played that video for them. And that there's some videos that are a little bit scary. The one that shows the cough assist of the cystic fibrosis patient from England, she takes a really intense treatment, and that's a little bit scary. She's used to it. But the one about the very first use in the United States, the Tyler Blake's news story, is about 2.5 minutes long. And for some reason, every time I've shown that to kids, it helps them to, they see it in a positive light. And even kids that were mentally challenged, if I could get them to pay attention for that 2.5 minutes and see that video, they were enthusiastic about using the Kuros after that. So if you are able to get that video where you can show it to somebody that's anxious, and it also helps to educate the family about it, because the doctor that talks at the end of that video, Dr. Peter Osbrew, gives a nice explanation of why BCV is a good therapy. Going into this process, you need to get some commitment from the patient and family. So you want to give them enough information for them to be able to tell you, yes, I want to go forward from here, or save you a lot of trouble. If they're going to put the brakes on and stop the whole process and refuse to go forward, it's better for them to do it early in rather than after you spend an hour or two trying to get the settings adjusted perfectly for them, and then they decide that they don't want it. So you want them to offer you a commitment. This is something that you really want, right? And then they'll usually say yes. If they're not sure, there may be additional questions that you need to answer before you get that commitment, but you need to get that done, and you'll have a lot better luck moving the patient through the rest of the steps of the process if you've got them to make that commitment. And as long as they clearly understand the goals and the benefits, that's really not a problem getting that commitment from them. But ask them to tell you, yes, I want to proceed through this before you go into it further. In some cases, you may actually size the Kuros, put it on the patient, and go through the settings. They may not be comfortable to give you a commitment until they've felt it on them, and that's fine. And I've had cases where I've gone into clinic and I've run the patient just really quickly. I said, this is how control mode feels. This is what secretion clearance feels like, and really don't make the adjustment, put the adjustment process into play. I just run through the settings real quick so they can feel it before we go into full adjustment. And that offers them enough information so they can say, yeah, this is not uncomfortable at all. Let's go ahead with the whole process. Now, we are doing this. We're selecting settings for the patient based on goals. So you want to establish those goals with the patient, and you want to keep them simple. We don't really want to assert that we're prolonging their life. Our goals for the patient are really simple. We want to provide their breathing muscles better rest, keep their airways as clear as possible, and help their breathing. And that basically is helping them to understand what the goals of the pulmonary care plan are, the care plan that the doctor has for them. And as we talked about in the setup module, when we're doing our setting selection, we want to determine why we're doing that. So start by determining the patient's problems and what they are and what our goals are before you begin. And I like to write them down. So I know I can refer back to that, okay, I'm doing this because, and I've got them noted down. And then if I feel like through the process I want to add to those, I can, but I want to note them from the beginning. Okay, so document those things that are based on patient historic data and your assessment under identified needs and expected outcomes. These will then go to the admission assessment that we've talked about previously. Okay, here is a partial list of problems that will potentially respond to BCV, very similar to the list of problems that we looked at in the setup presentation. Goals, here's a list of goals that may respond to BCV. Okay, so before you put the Curos on, you've already talked to them at some length, reinforce. They've given you a commitment, but reinforce what your benefits and goals of therapy are real briefly, and then initiate. You want to start with a baseline assessment. So what is the assessment data? If they're on another type of support, you're going to collect this data and note that it was on another type of support. If they're not on any other support, they're just breathing spontaneously, note that. And you want to include the basic information: heart rate, respiratory rate, blood pressure, pulse ox. If your titration is going to require in-tidal CO2 monitor, we can send you one and collect that data, spontaneous tidal volume and minute volume, which you'll collect with a soft steel mask and right, which if you're doing a complex titration, then we can send you those devices as well. Now, the training on use of the RTX is done during the setup process. It's not typically part of the setting selection process. So you don't want to spend too much time on specific elements such as placing the seals and the different elements that you need to put together, the tubing, the setting changes, Curos placement. If you get specific questions, you don't want to dodge them and say, we'll get to that later. You can answer them. But for the most part, the training on the use of the device will be part of the process that comes after setting selection, which is the setup process. And I'm doing this out of order, but I always like to start with setup, which is really one of the most basic parts of it. So training on actual use and application at home is done during the setup after setting selection is completed, and you don't need to cover that necessarily during the selection and validation of the setting. Initiate the setting selection process with sizing, and part of determining the right settings is determining the right Curos size. Sometimes you will think, well, that patient, based on the measurements I took or by his weight, should be a size 8. And then you'll find out a size 7 ventilates him better. Or you try a size 8, and during the titration, you just don't feel like he's getting what he needs, and you move him to an 8B or a 9, and that works better. Sometimes a smaller size gives you a better feel on the chest and moves the chest wall better. Sometimes a larger size gives you more mechanical advantage over a larger portion of the chest wall and abdomen, and that ventilates better. You just never quite know until you get into the process of determining the right setting of what Curos is right. So part of this process is maybe moving back and forth between different Curoses. So it's always good to have alternative Curoses available. You may project that the patient's Curos size needs to be a 6 or a 7, but if you determine that it's a 7, it's not a bad idea to have a 6 and an 8 on hand in case the patient ventilates better with the alternative sizes. Okay, and the primary guidance is always use the largest size Curos for which a good seal can be maintained. So if you get a good seal with an 8, and an 8 and a 7 fit the patient, use the 8. But if you get a better seal with the 7, then you do the 8 because the 8's a little bit too large, then the 7's going to be the answer. So you've got a balance there between the largest size Curos and the Curos that gives you the best seal, and you've got to determine which one ventilates the patient best, and that's the part of the process of selecting the right size Curos and part of selecting the setting. Okay, so another thing is you want to do your setting selection wherever the patient is going to be using the Curos most of the time. If they're going to be using it in bed, lying in bed is where they need to have the sizing determined. If they're going to be using it in the chair, tilted or reclined, it doesn't work well with them sitting all the way up at 90 degrees, but if they're going to use it tilted or reclined, then that's where you need to size the Curos. We do have patients that over time we determine that a second size is good for them, and we can get a physician's order, and we can submit that for authorization. But most typically, insurance providers won't authorize 2 Curos's to start out with. So you've got to determine which one works the best for them, where they're using it the most hours of the day. Okay, so we talked briefly about this in the setup process. For patients that are on other means of support and are totally dependent on that means of support, they may need gradual transition. And you have to bear in mind the ramp function of the RTX. So apply the RTX, allow it to reach the majority of the ramp before you remove the other means of support if they're totally dependent on that. And it can take, if there's on larger Curos's with higher settings, it can take 7 or 8 minutes, sometimes even 10 if there's a big leak, for them to reach those full ramp settings. So allow that time to occur before you begin backing down or removing the other means of support. Monitor your patients extra closely. Don't take it for granted that everything's going fine if you're in this transition process. You want to be very diligent until you've got them very stable on the RTX. Always try to avoid moving too quickly and causing anxiety or fear, or if there's any signs of pain, maybe the seal has come loose and the Curos is pressing, or it's just not seating right on them and it's uncomfortable. Be ready to back up for a second and then take another run at it. Don't rush the process. Once the anxiety begins to develop, a lot of times it's hard to stop it. So move very carefully and move very sensitively, and don't try to do your best not to let fear develop. Now, I talk about this. Those are rare cases. It's not a normal thing, but it's something just to be aware of. So if needed, revert back to baseline support, put them back on their other means of support, allow them to recover, and then proceed again more slowly the next time if needed. So initiate the setting selection process by recording baseline data on the setting selection flow sheet. The first column you won't necessarily be recording B2B settings, but you want to record your vital signs and other elements that you're monitoring with the setting selection process. Start by placing the seal on the Curon. Now this slide doesn't show it, but the straps go under first. The straps always go under first. So place your straps under your patient and put the Curos on the patient's chest. As we said before, be aware alternative sizes, larger or smaller, may work better. Record the Curos size initially, and if changed, there's a line on the form for noting that change of the Curos, so that as vital signs may improve, they'll improve after you noted the change in the Curos size on the flow sheet. Start with continuous negative. That's our standard process. Always start with continuous negative at a moderate pressure. Once you've achieved the pressure that you've got set for continuous negative, then bring the straps up onto the Curos. And again, I'm reminding you, but I've had it where patients, even fast movements at any time, they become anxious from. So don't move too fast. Move nice and slowly through the process, and tell the patient every step in advance. Your settings are selected for specific goals. So as you move into setting selection, your settings should result in determining or validating the settings which produce the most effective possible therapy for the problems and goals that we've established. Okay, so there is data. We want to monitor data to determine the appropriateness of the settings. So what we use for that, if we have a complex titration or a complex setting selection process, is going to be simple. We're going to use a respirometer and a pulse ox and an end-tidal CO2 monitor. If you don't have these elements available, ask for them if you have to do a titration. The clinical specialists all have them, or we at least have them available for them to get in order to take into these titrations. Oftentimes they're done in the hospital, so most of this type of stuff has already been done and is part of the documentation prior to getting the patient. But sometimes if we've got to do this for the patient, we need to get these tools to be able to do it with. For pediatrics, particularly infants, the respirometer is not going to be useful, and sometimes even the waveform that you get on end-tidal CO2 is not going to be that useful. So You're going to be doing it based on some standard settings, and then determine that they've got good signs and symptoms of being supported appropriately. As I said, for pediatrics, sometimes you can't get a mask seal, and you're not going to be able to use End-Tidal CO2 because you got so much of a leak, but you can use it maybe to determine synchrony and make sure that the waveform matches the waveform on the machine. All your patients, you should be able to monitor pulse oximetry. Okay, so we're using a respirometer attached to a soft seal mask to measure volumes. I'm not looking for exact specifics. We just want to make sure that our tidal volume is falling within a good range. So watch breath to breath. I usually reset every breath and just make sure that I'm getting, just kind of eyeballing the range of exhale volumes that I'm getting over 20 or 30 seconds. And then I take that kind of eyeballed average and multiply it times the respiratory rate, and then that gives me a ballpark minute volume. Okay, and I do that anytime that I make adjustments to rate or the span or the pressure differential on the machine to make sure that I'm still getting the right tidal volume range for the patient. And with the monitoring from the mask with the rights, you'll get some breaths that give you nothing back. And it may be because of a leak or the patient obstructed during that, such as maybe attempted to cough or just was talking, or for whatever reason they didn't give you a good exhale volume. So I take the good values where I know I'm getting good expiratory flow and record the average of those good values. And again, it's not going to measure well in low flows. So if your patient has extremely low flows, particularly tiny patients, the respirometer is not going to be much use. So those numbers, you may not record those numbers. Now, our goal for setting selection for BCV is to unload the patient. That's our biggest goal. So the patient should basically, in control mode, relax and allow the machine to lift up the load, take up the work of breathing. The idea being that if we completely unload them, when they need to breathe on their own and perform ADLs, because the majority of our patients do have some respiratory drive and the ability to generate a tidal volume. Well, the ability to generate tidal volume will be enhanced by good rest periods on BCV. So our most typical way of applying this is to apply it so that it picks up the patient's entire work of breathing, and that's what we want to pretty much see happen in order for them to get the fullest benefit from the device. So we want to give a tidal volume and a respiratory rate that achieves a minute volume that provides good muscle rest for the patient. They may take an occasional respiratory effort, but for the most part, they should be allowing the device to carry the work of breathing for them. And End-Tidal CO2 is going to verify that the patient is allowing the machine to breathe for them. You should have a smooth, even waveform that matches the waveform from within the cuirass. And all we're using End-Tidal CO2 for is it's not a real specific or exact value for many of these patients, particularly when measured through a mask. But we want to make sure that we're not driving their CO2 way down, or we're not allowing their CO2 to run really high and hypoventilating them. So we're looking for a ballpark range pretty broad. And we'll see those values here when we get to it. Also, we are adjusting to volume goals. And we're using our measured tidal volume to determine that we've got the pressure differential or span set adequately to meet the tidal volume needs of the patient. And our goal is 5 to 8 milliliters per kilogram of ideal body weight. So the formula for ideal body weight in kilograms for male is this here. For female is this. And a simple example, for a 5'6" female, we would set our, and this actually, the math here is not right. It should have been 58 times 5 milliliters to achieve the range that we have up here. So 58 times 5 milliliters is your low end of your range. 58 times 8 milliliters is the high end of the range. So probably about 300 to 450, 460 is the range that you want to achieve, or goal range for this patient, mid-300s to mid-400s. And that's the ballpark that you want to be measuring for your tidal volumes the majority of the time. Again, it's not controlling volume exactly. It's controlling volume by, if you alter the pressure differential, you get more volume exchange. If you lower the pressure differential, you get less volume exchange. So you're wanting to try to get tidal volumes within that 5 to 8 milliliters per kilogram ideal body weight. Also, we want our minute volume exchange to fall within a range that we can expect to keep CO2s within a normal range based on a normal metabolic rate. And we want that to, we're going to achieve a goal or determine a goal minute volume, and we want to be within 80 to 120% of that goal minute volume or basal minute volume that we know should give a normal CO2 for a normal metabolic rate. Our goal is set based on standard minute volume standard minute volume determination criteria, which is 3.5 times body surface area for females, 4.0 times body surface area for males. Body surface area is estimated with this formula here. Okay, so height in inches times weight in pounds divided by 6262. And here's an example. In this example, our goal minute volume is going to be 4.4 to 6.6 liters per minute. And for a female 5'6" female, 4.4 to 6.6 liters per minute should be able to give us a arterial CO2 within the normal range. We measure with the respirometer and soft feel mask. There is a item that can be requested from our warehouse that is a titration kit, or it's a ventilation monitoring kit, and it includes a one-way valve. So when this image was shot, that one-way valve set wasn't available, but you can have the patient inspire from the room and then exhale out through the filter into the right, so they're not breathing back in from the right. But this can be done this way, and you see the end-tidal CO2 monitor is in line of the respirometer as well. So you're getting end-tidal CO2 and respirometer data at the same time. You can get a cannula for the end-tidal CO2 monitor, and it will pull through a end-tidal CO2 monitoring cannula if you desire to do it that way. But it's harder to get a good seal on the mask and get your volume estimate if you're using the cannula. So it's 6 1/2 dozen the other. Some people do it one way, some another. One of our other goals that we're titrating for, besides normal end-tidal CO2 and normal tidal volume and minute volume, is comfort. And this is very important. So as you make adjustments to the settings, request subjective evaluation from the patient. And I compare it to an eye exam. You may just try a setting on the patient and say, how does this feel? Let me alter the IE ratio a little bit. How does that feel? And then go back and forth. Oftentimes, IE ratio is set as a factor of patient comfort for long-term use. So you might just try a little bit more of this, a little bit more of that. And one thing to bear in mind, which to me is kind of surprising from the titrations I've done, many patients prefer a longer inspiratory than expiratory time. So they may like an IE ratio of 1.5 to 1 or 2 to 1 as more comfortable for them. And due to the fact that we have an active expiratory phase, we're helping the patient to exhale. Air trapping or auto PEEP with a inverse, or what we would normally consider an inverse IE ratio, is not a problem with this device. And if the patient's more comfortable, they're going to be more compliant. So it's not a big concern if you do titrate or adjust the settings slightly toward a longer inspiratory time. So proceed through your modes and setting variations within the modes until your desired endpoint that we described are reached. In control mode, you're going to vary the inspiratory and expiratory pressure and inspiratory and expiratory phase timing and rate until it's maximized for the patient. Use your end-tidal CO2 wave and rate to make sure the patient's synchronous with the device. So if your machine is cycling at a rate of 24, your end-tidal CO2 waveform should be showing 24 cycles a minute and reading a rate of 24 as well. So those waveforms should match. Otherwise, your patient may be not getting quite enough span to allow the machine to lift the load, or they may need just a little bit more time. But you want about 90% of the machine cycles to be reflected as patient breaths, at least. Now, respiratory synchronized is another mode that we may use. And in respiratory synchronized, we won't get complete unloading because the rate is based on patient effort. So they're still going to have to make some effort. However, some patients are just more comfortable on respiratory synchronized. They have an intact respiratory drive they just need tidal volume support. And some patients, particularly that I found COPD patients, just prefer respiratory synchronized. So in respiratory synchronized, you're using a sensing cannula under their nose, or if they have an artificial airway, you may be adapting the airway adapter over the trach tube, but somehow you've got to be able to sense respiratory effort back at the machine. And in respiratory synchronized, you're just adjusting the inspiratory and the expiratory pressure. And you're titrating for patient feedback. You're trying to achieve the correct tidal volume and minute volume range, but you're not able to control IE ratio in this mode. So you're still looking for the same type of data, or your same type of endpoint. And for the patient, if they're more comfortable on respiratory synchronized, then that's fine. But it's not going to achieve complete unloading. So it may not be as advantageous for patients that we want to give full rest so they have more capabilities in between use of the device. But whatever works best for the patient is going to be what they're going to be most compliant with. And in respiratory synchronized, we want them to have one-to-one synchrony with the device. So for every respiratory effort that they make, we should have a cycle from the machine. Now, the manufacturer guideline for the percent of triggers, and there is a value that comes on the unit in respiratory synchronized called percent of triggers, and that should be 85 to under 100%. So 85 to 99%. If it's 100%, you may be getting auto cycles. If it's below 85, the patient's making efforts that aren't being sensed by the machine. So you want it to be, again, 85 to 99. Our goal is to try to get it as close as possible to each effort that the patient made should be result in a trigger from the machine. Now, there is a mode called respiratory triggered on the RTX. We don't recommend using that. It is generally found to be uncomfortable for the patient. So either control mode or respiratory synchronized. There has been confusion, and I've had phone calls. It was interesting from one facility with a doctor who represented one side of the argument, which was the physicians, called me, and then a day later, a respiratory therapist who represented the other side of the argument called me, and they were arguing that respiratory synchronized was like SIMV on positive pressure ventilation. That was the physician side, and then the respiratory therapist would say, no, it's more like pressure support on positive pressure ventilation. Well, it is probably the BCV version of pressure support. Every inspiratory effort should and generally does result in an inspiratory phase on the Hayek. At the end of inspiration, it switches into exhalation. With SIMV, it gives the number of breaths per minute set on the machine synchronized with patient effort, but not every single breath receives full support. So it is more like the pressure support version, if that question ever arises. Okay, so as you move through your support settings, note level of patient synchrony and measured data. At the end of the process of determining settings, a progress note is required as a summary, if nothing else, and note also anything pertinent that wasn't being able to be entered on the flow sheet. Note your reason for any final settings that result in recorded values outside of our recommended range. And at a minimum, we need a summary of the process. Okay, and we'll look at those correct ranges. I believe they come up in a few more slides. Secretion clearance and cough assist is a separate process of setting determination. So you want to provide standard settings for the goals, going through the treatment at least one full cycle of oscillation and assist cough. Oscillation frequency should be from 6 to 800. Okay, 600 is for very thick, difficult to clear out secretions. 800 is our more standard setting that we initiate at. 800 works well for most patients. Below 600 is very intense. As you lower the rate, you get more of a volume exchange, and it can make the patient dizzy and uncomfortable below 600. Some patients like that intensity, and if that's the case and they express preference for it, then, and this is particularly cystic fibrosis patients, but if they express a preference for a lower frequency, The machine goes as low as 240. I have never set anybody on chest wall oscillation at that range, but I have had a couple of cystic fibrosis patients that liked 450. But normal is going to be 600 to 800. Higher than 800 is such a fine oscillation that it doesn't have a full effect on thinning the secretions. So you'll go higher than 800, generally only for tiny patients or patients that complain initially about 800. So if they have a comfort issue at 800, then you might try 850, 900, 1,000. It goes as high as 1,200. But for adults, that's a very rare setting selection. You're just not going to have much effect or as much effect as you would like in the thoracically at that setting. But for your infants, 1,000 to 1,200 is perfectly acceptable. As I said previously, I like a cough rate of 24 per minute, just because graphically, when the full screen is up there, you've gotten rid of the setting choices and the alarm settings. They're off the screen. At that width, the sweep puts one cough on top of the previous cough at the same point in the graph, so the patient is able to learn and determine when to place their own cough effort. And 24 minutes just really works well for me. The total duration of the treatment, which is oscillation plus cough assist phase times the number of repeats, should be at least 20 minutes. A standard secretion clearance treatment will be oscillation, 800 cycles per minute. There's an inspiratory pressure value that is the intensity of the oscillation. That should be anywhere from minus 15 to minus 30 based on the size of your patient, small to large. And then you're going to set the duration of oscillation typically at 4 minutes. Then you're going to set an inspiratory and an expiratory pressure for the cough assist. The range there is minus 35 plus 35 for your largest patients, down to minus 15 plus 15 for your smallest patients, or maybe even slightly less than that for a tiny infant. And then your cough assist frequency normally is going to be, like I said, it's 24 cycles per minute. And then your repeat is going to be 5 times. So if you're doing 4 minutes of oscillation, 2 minutes of cough, or a repeat of 5 times, that's a 30-minute treatment. And that's a normal secretion clearance prescription right there. Okay, you want to keep your settings as close as possible within the guidelines that we normally see. You don't want to get out in left field unless there's a really strong reason. And if you are off what we consider normal, we need extra documentation as to why that you had to do that. So your adjustments and final results should be measured within guidelines. Now, one of the key elements that, and we haven't covered this before, so just so you know, your key elements of the guidelines of your final setting, mean Curos pressure. So on the upper left-hand corner of the screen is the pressures from within the Curos. You get inspiratory and expiratory measured pressure, and then you get a mean Curos pressure value. That mean Curos pressure at the end of titration, at the end of full ramp, should be more negative than -4. Whenever possible, you want to keep the negative to positive pressure balance at 3 to 1. For example, a -24 plus 8. So your negative is 3 times your positive. And also, you should never have a pressure differential or span less than 10 centimeters. It should always be more than 10 centimeters. Most typically, it's going to be 20 to 40 centimeter span. Oscillation rate should be between 6 and 800. So these are the normal ranges of settings. So you want to try to stay within those if at all possible. If you're using unusually low or high settings, make notes to support why you did that. Again, spans should be 20 to 40 or indicate why not. If you're using a prolonged inspiratory or an expiratory time and they're required for patient comfort, just note specifically why you did that. But remember, the golden rule of this is -4 mean Curos pressure or more negative. So if you start using prolonged expiratory time, make sure that after fully ramped, you're not more positive than -4. If you're on a 0 mean Curos pressure, over time, you're emptying the lung and you're going to create problems for the patient. So mean Curos pressure always needs to be more negative than -4. If mean Curos pressure is not more negative than -4, or it is more negative than -20, note the reason that you set those settings in that place. The cycles per minute for secretion clearance or for support should usually be within the normal respiratory rate range for the size of the patient. So pediatric patients that normally breathe 30 to 50 times a minute shouldn't be on a rate of 12. Adults that normally breathe 12 to 20 times a minute shouldn't be on a rate of 60, most typically. But if that's where they wind up through the process outside of those normal ranges, note why they needed to be there. Okay, once you've got your final settings determined, allow a nice period of the patient to settle onto those settings and verify tolerance and ongoing stability. A real clear indication that the patient is comfortable on your settings is that they will sometimes just fall asleep. They'll be very comfortable. The level of support is right and the level of comfort is right. They should feel no anxiety about it, and it should be very easy for them. And like I said, a really good indication is that they just relax off to sleep. I've seen it happen before. Now, there is a unique application we're going to talk briefly about, and that's the NEV100 portalung patients. We don't encounter those patients very often, but I just want to put a brief note. If you have one that you need to put on an RTX, what we do is basically mimic the span and the timing that are on the NEV100. NEV100 is an old Kuros ventilator that's no longer supported, and a portalung is basically a fiberglass version of the iron lung. And we are getting some patients that are being referred to us that are on that combination, and the RTX is able to provide support for a patient in a portalung, but we do have to make sure that everything is safe for them. So you're going to mimic the settings that were on the NEV100 with the RTX, match breath timing as best as possible. With the NEV100, that device did not have the same ramp function that the RTX does, so it's often a good idea just to let them know that it takes a minute or two for full settings to be reached so that they are not distressed during that period. And then once you've gotten the patient up on the Hayek at settings that are mimicking the NEV100 settings, then you can just make adjustments to achieve the desired effect based on the same or similar instructions that we just gave. Okay, so when you want to transcribe your notes and flow sheets to electronic format, or you want to fax them in. Here is an example of a titration flow sheet and initial baseline settings. Started out in CNAP and then went into control. One element that wasn't obtained here was a set of numbers before the beginning. So there should have been some vital signs that were obtained before we even initiated CNAP on the patient. Here's a note relating the events of the titration. Okay, and then this is the setting selection process. Educate, determine problems and goals, record data, size the patient, initiate the process. Start with CNAP, know your goals, proceed through the modes and settings, verify tolerance, and then send your notes in. Okay, the guidelines for your settings and measure results. As we said, if you fall outside of these ranges, you really want to document clearly why you were. Those ranges are the pressure differential or span should always be between 20 and 40 centimeters. So in other words, and again, at least 10 centimeters, but generally normal chest wall compliance and normal lung compliance, that combination, I have found that about 30 centimeters gives you a 6 milliliter per kilogram tidal volume exchange. Some patients require a little bit more than 30 centimeters. Some patients require a little bit less than 30 centimeters. Some will ventilate fine on a 12 centimeter span, but those are rare patients, and they have very flexible chest walls and very good lung compliance. Some patients will take 44 or 50 centimeters of span to give them the right tidal volume. The thing to bear in mind as you adjust span is what we put on the outside of the chest, only about a fourth to a fifth of that centimeters of water pressure is actually delivered to the lung. So it's not like a 40 centimeter peak pressure on a positive pressure ventilator. It's far less potential for damage to the lung. And then it becomes more of a comfort factor for the patient when you start having these large spans But sometimes that's what's necessary to give them a normal tidal volume. So a span of 40, for example, would be a minus 30 plus 10. That span of 40 may be what is required to give that patient the normal tidal volume that we're wanting to get. Again, our mean Kuros pressure should always be more negative than minus 4. Now, if our settings require rates greater than 60, we don't worry about that anymore, because when you go to a rate greater than 60, you balance IE ratio and you go to even pressures. So your minus 30 plus 40 becomes a minus 15 plus 15. That's the standard guidance of using a device. Your tidal volume should be in that 5 to 8 milliliter per kilogram of ideal body weight range. Your minute volume should be in that 80 to 120% of predicted basal minute volume. And tidal CO2 values should be within the range of 30 to 50. Again, all we're trying to do is make sure we're not hyper or hypoventilating in the extreme. Your SAT should be greater than 91%. And if they're on oxygen while they're on the device, specify that they're on oxygen. Some patients are on low-flow oxygen while they use RTX at home, and that may be required for them to achieve adequate pulse oximetry. Most patients are not, but some are. The respiratory rate range that's set on the machine should be in the normal range for the patient size and type. And if your synchrony goal with your end-tidal CO2 waveform should be greater than 90%, and in your oscillation for secretion clearance, your frequency should be between 6 and 800 and not too far below or above that range for a specific reason. So as the person helping to determine the correct settings for the patient, you are a key part of the vision. And Dr. Hayek, here's a copy of Dr. Hayek's patent, and Dr. Hayek's vision was to create a device that would provide complete ventilation, be non-invasive, work physiologically, be simple to use, and that would overcome many of the problems associated with existing ventilation techniques, and provide a better quality of life for patients that are ventilator dependent. And as an individual helping to determine the right settings for the patient, you are a key part of achieving that vision. I think that ends our setting selection. Okay, so now we're going to wrap up with follow-up procedures for the biphasic Kuros ventilation patient at home. This is for your subsequent visits. Our standard visit protocol is to follow up with the patient monthly. If the patient is a patient that needs to be followed up with monthly, then we try to get in and see them every month and just collect a little bit of data and to follow up on them. Some patients are very stable and they may not need to be followed up on monthly, and that determination is made on previous follow-up visits. But for the most part, our BCV patients are monthly follow-up patients. So follow-up process for these patients. Now, just to kind of review what we've talked about, there are 3 phases of BCV patients in the home. First of all is the referral and intake process. So this is where a physician or a case manager or someone refers the patient to personal support for following at home. And that is prior to us doing any titration or setup or anything. So that's the initial part of the process. And then setup, where we may determine setting selection. That may again be determined in the hospital or clinic, but as part of the setup, we may be selecting the settings or at least validating that they're appropriate for the patient. And then in the setup process, we're training the patient and the family on BCV use. And then we complete the admission assessment and care planning process in that setup phase. And then we have follow-up, which is what we're talking about now. So some of the things that should have come forward from the initial setting selection process: the initial determination of the problems and the goals for the patient, the selection of the settings, and the documentation of why those settings and the Kuros sizes were chosen, the notation of the reason for any of those settings that are outside of the normal range, and the patient and family should be introduced to the concept of BCV at the initial introduction to the device. Training for use will not have been done at this point. That is done during the setup phase. And at any point in time, if you are not the person who did the setting selection, you can check in with the home office, and they can put you in touch with the individual that did if it was a personal support clinician. And you might need some additional background information on why those settings are chosen, and you can contact that individual, and they can help you out with that. From the setup process, coming forward to the follow-up process, in the setup, we did the completed mission assessment, collected that data, documented the machine settings and initial physical findings at the time of setup. So that documentation, that information should have come to you from the setup, and also the final specification of the care plan, long-term problems and goals. That care plan is carried forward throughout follow-up processes unless there's a significant change of condition, and then we can update the care plan at different points in the follow-up process. Okay. So also at the setup process, the patient and family get their initial education and training and should be well introduced to the concepts of BCV and of the use of the RTX. However, during follow-up, we can certainly reinforce those. So prior to your visit, verify and review your orders from the initial assessment, review the patient's historical data if provided to you as needed, review your plan of care. The visit may be scheduled for you. In some cases, Michelle is scheduling the visit for the clinicians, or you may schedule it for yourself, and then contact the patient or family a couple days before and confirm that you'll be dropping by. Call ahead 30 minutes before if possible. Most people nowadays don't like to be surprised by somebody showing up at their door and they might have forgot that you called them, so it's not a bad idea to just call ahead and say, I'm going to be over there in about 30 minutes. If you've been watching some of the Goldberg's comedy, the father may be like that father sitting around in his underdrawers, so you want to let him know, put the pants on. Arrive promptly. Also, you should have your personal support name badge with your scrub attire. At the door, introduce yourself as a clinician. As a clinician doing follow-ups, you're representing personal support medical supply. Hayek Medical is the distributor of the Hayek, but personal support medical supply is the home care provider of the Hayek. During the brief period, discussing their previous experiences, review their goals and expectations, correct any misunderstandings, and reinforce the benefits of use. Go over what you're going to go through in the follow-up process, outline a little bit of paperwork that is to be covered with them. We're going to do an equipment inspection. Make sure the machine is all together, there's nothing broken, all the supplies that are needed are there. Go through the settings on the machine in all modes and make sure that the settings are appropriate or aren't way out in left field, and that the settings in the modes that are supposed to be active are as ordered. And this one's on no wild settings. I mentioned it before. Sometimes machines will be, in the inspection process, will be put on a -50, which is the upper range. They shouldn't be left in anybody's home still set on -50 in case that mode where -50 is the setting. If they accidentally go into that mode, you don't want them to be getting those crazy settings. So make sure the settings, even in unused mode, are somewhat reflective of the prescribed modes. Note the hours on the unit. That's part of inspecting the equipment. So power the machine up and note the hours. If the patient is using it, you're going to need them to have it off for a second, just unhook the hose, or just turn the machine off. Hopefully they can breathe on their own for a minute. They may need some mask support for a brief period if they're a full support patient. Power the machine up and note the hours on the machine as part of your follow-up assessment. Note when the next maintenance is due, and that's going to go on your documentation. If there is maintenance that is due by the sticker on the side of the machine, please bring that to the attention of Michelle when you send in your paperwork. Okay, our follow-up paperwork is our clinical respiratory care visit form, a delivery ticket, and a patient note. Follow-up has probably the simplest paperwork. Okay, so our respiratory care visit form, as always, leave no blank unfilled. If it's NA, enter NA. Review for changes since your last visit and enter. A lot of times, the main basic data is not going to be that different. Their tube feed's still going to be flowing at $50 an hour, or they're still on the same medications, but there are any changes that have occurred, though, you want to update them. And then complete your patient assessment, which oftentimes is just collecting some basic vital signs and then the data. Enter a complete SOAP note based on your findings. The SOAP notes are where we document any short-term issues and how we're addressing them. Okay, no part of this form is optional. Okay, so SOAP, for people that aren't familiar with SOAP notes, so S is subjective, means only what the patient tells you, symptoms, attributions, etc., or what you know to have occurred in the past, patterns of use, such as increased hours of use per day, do not indicate impressions or results of your physical exam, and subjective. And then we have objective, which is the results of your physical exam and interval data summarized. Assessment is the A, includes your interpretation of information in the previous two sections and your assessment data. And then plan is the P of the SOAP note, which is what you're going to do in the short term about your impressions. Our clinical respiratory care visit form, note any supplies that you dispense to the patient and supplies on hand. Most typically, the patient is going to be receiving supplies from the home office based on their expressed need or any follow-up calls that are done from the home office. So it's rare that you will need to dispense supplies. But if you do, note that on the delivery ticket, and also let the home office know that you had to dispense supplies if you have extras. Document the RTX modules that are in use and settings that as ordered. Most patients should have the 3 modules of ventilation, oscillation, and cough assist in use. Fill out the form completely, including hours and next maintenance due for all modules in use. If there's any additional DME in use for the patient, this will be documented in a similar format on a blank sheet of paper. Okay, so you're also going to document your care plan on this form. And the care plan should be essentially the same care plan from the setup and from your last follow-up visit, if you've done prior follow-up visits, unless there is a change of condition. So the care plan is really pretty simple. You're just transcribing it forward. Short-term issues go in your SOAP note or your progress note, not your care plan. If there is a significant change of condition, document a new admission assessment with an updated care plan, noting the reasons for the changes for submission. And again, all these should be specific to the patient's symptoms and diagnosis as we discussed in the setup module. Okay, so here is an example of your respiratory care visit form. You're asking the patient, you're getting patient data at the top, demographics, and then has there been change of insurance? Have they gone on hospice? Have they gone to the hospital? We need to note the date range if they were in the hospital and why. If they were, have they had any infections? Have they had any changes in medication or changes in DME? So any new DME equipment that's in the home. What are their sleep habits? Probably no different than the last time you were there. What's their diet and appetite? Their mental evaluation, vital signs, breath sounds, pulse oximetry, oxygen use, sputum, and SOAP note. Here we have page 2. So any supplies that you might have dispensed, any supplies that might be needed, quantity of items on hand. Then we have our Hayek. So again, we're seeing the same as we saw in the setup where we're doing the RTX-V and the serial number -V, and you're getting that same RTX-O and serial number -O, RTX-C for the oscillation and cough assist modules. And then our plan of care, this should say 3 right there, but our 1, 2, 3 problems, 1, 2, 3 goals, and 1, 2, 3 actions. And then actions to take in case problems occur when those respiratory practitioners present, up to including calling 911. And patient continues to require clinical respiratory care services, yes or no. At this point, if the patient is extremely stable and doesn't require future visits, you can say they're not clinical. But if they are requiring future visits, and most of our RTX patients are requiring vet support, so they continue to require follow-up visits. And then you sign it. There's not a place here for a family member to sign. Okay, then the delivery ticket, make sure all the data is correct. If you need to amend it by hand, do so, and then have the patient or representative sign and you sign. Generally, no additional entry on this form is needed except the date and the signature. And perhaps if the patient isn't able to sign, the reason the representative has to sign due to patient ability or patient unable, and who it was, mother or father. If you've got some unexpected or unplanned supply provision, note the supplies that you left there, and you want to make sure the home office is aware that you're leaving supplies so that they can help get the delivery ticket corrected when it comes back into them. Respond to any questions, reinforce where needed. You want to verify that the service equipment is meeting their needs at a level of excellence. We want to really have the patient to have a really good experience. So follow up with them and make sure that we're covering all the bases for them, that they're not having problems with our home office, they're not having problems with the communication, and that you've provided a good service. If they're not experiencing things on that level, determine why and work to resolve it. If you can't resolve it, work with the clinical specialist for the region, or someone else at the home office can help you to get the patient's issues resolved. Okay, you also have a patient note. Patient note is optional with your follow-up visit. If everything that you needed to say was covered in your SOAP note and the documentation on the follow-up form, then you don't need a note. But if you need to add more than that allows you, or you need to be more specific, or you have more data that you want to say, then enter a patient note. Okay. However, remember, the note is part of the record. So don't say, please send the patient 3 seals on your follow-up visit note. That would be something that you could send in an email or call the home office and let them know about. It doesn't need, it's not to be part of your progress note or your SOAP note. Make sure that they still know how to get a hold of us at the home office. And if you're comfortable giving them your contact information, that's fine as well. And then transmit everything electronically via fax or email to the home office as soon as you can following your follow-up visit. And that completes the follow-up training. So, just as a matter of summary, the modules that we covered were the setup, the setting selection, and the follow-up modules. There's an introduction module that is a PowerPoint presentation that everyone should also view, that gives you an overview of how the RTX works and some of its capabilities, some basic information on it. And we'd like everybody to do that as well. And then there's one more element to your training, which is your hands-on clinical competency, which is done with you at the time when you do your very first patient setup or follow-up. And that'll be completed with either your regional clinical specialist or our clinical educator, or myself. I'm Gary Mefford. I'm your Vice President of Clinical Operations. So one of us will be doing that hands-on. We'll basically cover entering settings and applying the seal and assembling the equipment on the machine. And it's really not complex, but it's the final element of your training. So the 4 modules: introduction, setup, setting selection, follow-up, and the competency. And once all those things are completed, you're a fully fledged per diem clinician with Hayek medical and personal support. And I just want to take this opportunity to welcome you aboard. I am always available to help you. If you're not getting help through the other contacts that you have, please feel free to contact me. My email number is gary.mefford, Gary.mefford at Hayek, Hayek medical, all one word, .com. Gary.mefford at hayekmedical.com. Please feel free to contact me if I can help you with anything. But thank you for your time and attention on this training module. And really, this is, for us all here at Hayek and at Personal Support, our RTX ventilation program is really about providing a better way for patients that need pulmonary support. And we really, really do believe, and when you see this work, you'll understand why we do believe that this is just better. Patients can eat and drink and speak while they're fully supported. There is never ever been, and I've been doing this a long enough time to know there's never been anything that provides the potential for secretion clearance to the patient that this device provides. It is an awesome tool for clearing patients' airways and helping to get their lungs in shape. So thank you very much for your time on this, and we appreciate you. And if there's anything that I can do for you, please let me know. And you have your contact at personal support and your regional clinical specialist. Please use them as you need, and enjoy helping us to follow our patients. Thank you.